This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and today we are diving into a topic that is bread and butter for any neurosurgical service, yet remains a source of significant procedural concern.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the Journal of Clinical Neuroscience, slated for the 2026 volume. It's titled, Influence of the Correct Placement of External Ventricular Drainage on Puncture Channel Bleeding in Patients with Aneurysmal Subarachnoid Hemorrhage.
This is a vital piece of research, Alara. We perform ventriculostomies almost daily for aSAH patients to manage hydrocephalus and monitor ICP. While we know hemorrhages can happen during EVD placement, this study specifically looks at puncture channel bleeding, or PCB, and how our accuracy as surgeons directly impacts that risk.
Exactly. The researchers looked at 127 patients with aneurysmal subarachnoid hemorrhage who underwent both EVD placement and aneurysm treatment between September 2021 and June 2025. They pulled this data from a prospectively maintained registry.
Now, before we get into the results, how did they define correct placement? In the heat of the ER or the OR, we always aim for the foramen of Monro, but their criteria were quite specific.
They classified EVD positioning into two groups. Correct placement was defined as the catheter tip being ipsilateral interventricular. Incorrect placement included trajectories that ended up contralateral or remained intraparenchymal. They then looked at post-procedural CT scans to identify PCB, which they defined as any hemorrhage along the catheter tract.
And what did the numbers show?
The overall incidence of PCB occurred in 20% of patients, but when you break it down by accuracy, the difference is staggering. In cases where the EVD was malpositioned, PCB occurred in 56% of patients. Compare that to only 15% in the correctly positioned group.
That is a significant jump. A p-value of less than 0.001 really emphasizes that this isn't just a random occurrence. What did the multivariable logistic regression show?
This is the most critical takeaway. Incorrect EVD placement remained the only independent predictor of PCB. They found an odds ratio of 7.8. Essentially, if the trajectory is incorrect, the risk of a puncture channel bleed increases nearly 8-fold.
Now, Alara, let's talk about a major concern for us when treating these patients: medications. Many aSAH patients are on pre-admission antiplatelets or anticoagulants, or we might start peri-interventional antiplatelets for stenting or flow diversion. Did the study find that these drugs contributed to the bleeding risk?
Interestingly, no. The study found that neither pre-admission antiplatelet or anticoagulation therapy nor peri-interventional antiplatelet therapy was significantly associated with PCB. All those factors had a p-value of 0.5. It really highlights that the mechanical trajectory of the catheter matters more than the patient's coagulation status in this specific cohort.
That's a bit of a relief for the endovascular team, but it puts the pressure back on the resident or attending performing the bedside procedure. Now, let's talk about the clinical so what. Does a little bit of blood along a 6 French catheter tract actually change how the patient does?
The study looked at two main areas: functional outcomes using the Modified Rankin Scale, MRS, and cognitive outcomes using the Montreal Cognitive Assessment, MoCA. In the univariate analysis, functional outcome at discharge and at 3 months didn't look significantly different, p-values of 0.43 and 0.28.
But univariate analysis can be misleading because these patients are already quite sick from the initial hemorrhage. Did they adjust for that?
They did. In the multivariate analysis, adjusting for age and clinical severity, PCB was independently associated with a lower likelihood of a favorable functional outcome. At discharge, the odds ratio was 0.19, and at 3 months, it was 0.10.
So while the cognitive outcome measured by MoCA wasn't significantly affected, the physical, functional recovery was clearly hindered by the presence of a puncture channel bleed.
Correct. The authors concluded that incorrect EVD placement is a strong and independent risk factor for PCB, whereas the pharmacological factors we often worry about didn't significantly influence that specific bleeding risk.
It's a powerful reminder for all of us. Accuracy isn't just about making the EVD work for drainage. It's about minimizing procedure-related complications that have real-world impacts on patient recovery. For our residents listening, take that extra moment to confirm your landmarks. The trajectory is the most important variable you can control.
These findings really highlight the critical importance of accurate catheter trajectory in reducing complications and improving overall outcomes in neurovascular care.
Well said. That's all for today's episode of the Neurosurgery Hub podcast. Thank you for joining us.
See you next time.